ceded Algonquin and Anishinaabe territory. The people of Algonquin and Anishinaabe Nation have lived on this territory for millennium, and we honor them on this land. Their culture and presence have nurtured and continue to nurture this land. So today is the Stanley Mercer Research Day, and before I introduce our visiting professor, we know Dr. Mercer. He was the first pediatric surgeon in the Ottawa area, and he became a major force behind the creation of CHEO, where he was the chief of surgery from CHEO inception until his retirement in 1989. He was founder of the Canadian Association of Pediatric Surgeons, and he was a member of the board and governor of CHEO Foundation. Today, our visiting professor is Dr. Mary Brindle. Dr. Brindle, well, I can spend an hour talking about her achievement, but I'll be very precise. So Dr. Brindle is a professor of surgery and community health science at the McNeil Chair of Pediatric Surgery Research at the University of Calgary. She also led the Safe Surgery program at the Ariadne Lab in Harvard, and she is the Secretary General of the ERAS Society. Her internationally recognized research focuses on surgical safety, system improvement, and healthcare innovation. And on a personal level, she was my fellow, and I always tell her that she was the reason why I got into pediatric surgery. She's a role model. You achieved a lot, and you're so humble. So it was a pleasure to be a resident one day and a colleague now. So she's going to talk to us about reliability in the face of fragility, system approach to neonatal surgery. Mary, thank you so much for coming. Yeah.
Thank you so much. I'm really excited to be here, and to be able to work with Ahmed again is fantastic. We were just reminiscing about the fact that we'd always kind of expected that we'd have an opportunity to work together, and being able to be here and visit in Ottawa is really excellent. And so today I'm going to be talking a bit about a systems approach to neonatal surgery and how we can think about improving neonatal care. So in terms of disclosures, I do have grants. I've received grants from a number of different government organizations and agencies. I have no industry funding, and I have a number of relationships with different academic institutions. I also live and work in Calgary, which is the traditional territories of the Blackfoot Confederacy, the Tsuut'ina First Nations, as well as the Stoney Nakoda peoples. And they have been really instrumental in developing our equity arm of the Equus research platform where I work. So I'm hoping by the end of this talk that we'll be able to recognize some of the key physiologic and systems-based risks that contribute to adverse outcomes in neonatal surgery, that we can think about how ERAS principles can be adapted to the neonatal population despite our limited high-quality evidence, and to identify practical strategies to implement and sustain programs like enhanced recovery after surgery and tools like the surgical safety checklist in pediatric surgical settings. So very briefly, a little bit about the work that I do at Ariadne Labs, because this was a bit of an inspiration for me in terms of the direction I've taken over the last several years. So just at the beginning of the pandemic, I was recruited to take on this position of Director of Safe Surgery and Safe Systems, which is located at Harvard within the Harvard School of Public Health and Brigham and Women's. And this has been a really interesting and eye-opening way for me to think about the sort of work that I do in systems improvement. So as a university kind of department, one of the things that I first noticed is that the way that Ariadne measured metrics of success were not in things like grants achieved or publications. They were really focused on lives touched. So this is stats back from 2021. Right now we're over 100 million lives touched. And some of the things that we look at are the tools that are developed and disseminated, the countries in which our work is accessed, the health systems that we've been able to work with, and the healthcare providers that we've reached. So a really different way of thinking about impact, which I've always found has been very inspiring for me. The two areas that I spend a great deal of my time in terms of surgical quality improvement and safe surgery are in the surgical safety checklist and enhanced recovery after surgery. And I'll describe these in a little bit more detail. And this is going to form a little bit of the structure of my talk today. So in pediatric surgery, we were just sort of talking about this before, the scope of patients that we manage is extraordinarily broad. There can be a day when at the beginning of the day I'll be operating on a 400-gram infant who's got perforated necrotizing enterocolitis, and then later that day I can operate on a 100-kilogram bulky teenager who's got gallbladder-related disease. And this huge patients can really add challenges to what we do and also make it difficult to reflect on where the greatest needs are in pediatric surgery. I'll also say that sometimes we run into challenges when we're advocating for pediatric surgical resources in that we have this huge number of relatively low-risk, healthy patients who do extraordinarily well after surgery, and it can sometimes mask the fact that within our population we have extremely high-risk patients as well. And so one of the areas that I spend a lot of my time thinking about is neonatal surgery. And this patient population does significantly worse than any other age range populations except for the extreme elderly patients. And the outcomes after surgery are really anywhere near as good as they could be. So if we look across the United States at their outcomes after surgery for term infants, the mortality rates are about 2% at 30 days. And for preterms, they're about 5%. So these are inpatient surgeries that are being performed. Those are very high numbers. And the morbidity rates are also extraordinarily high, 17.4% for term infants, 27% for preterm infants. And when we look at places that have fewer resources than we do, in a place like Ottawa, we see that, the disparities between where we feel we should be in terms of our outcomes, where we actually are, is even greater. So a country like Canada, we have mortality rates of about 2.7%, and countries that have a low human development index or low resource settings will have mortality rates around 17% for 30 days. And there's a number of reasons why we have this disparity and this gap between where we should be and where we are right now. And if we look at some of the physiologic factors, there are a lot of them. I mean, our infants have small blood volumes, immature immune systems. It's very difficult to maintain a good fluid balance, poorly able to regulate their temperatures, poor oxygen reserves, poor glycogen reserves. They have very fragile CNS systems, which are very prone to injury. I'll often show this picture of a small beaker to my colleagues, and the amount of blood that our smallest patients have would not even fill this beaker, and this amount of blood is the sort of thing that an adult surgeon wouldn't even chart because they regard it as being nothing. So our patients are significantly more fragile. But there are also significant system barriers to the care that we provide patients, and we don't always think about these. So pediatric surgical care is fragmented. We have very rare conditions that are spread over a large geographic area, multiple clinicians. It's really, really difficult to get good evidence for these patients, to bring data together in a way that we can understand it and improve care. And this leads, of course, to these information gaps. When we don't have good evidence, we tend to start to stick with what we know. We run into those issues of surgical hierarchies where eminence exceeds evidence, and care is performed as it always has been for the last several decades. It's not a surprise that many of the practices that we look at in pediatric surgery that are standard are things that have been rejected in the adult world at least a decade before. And it also is very difficult to prioritize pediatric surgical care because we are dealing with these rare populations, and that often gets lost in this large surgical systems in which we work. Many of us have really been able to benefit our populations by recognizing that children are not just small adults. And this has really been a basis for a lot of pediatric surgery and pediatric research and understanding the physiologic and social differences that children have versus adults. But this is a little bit of a double-edged sword. One of the things that we also have encountered is that because of our feeling that children need things that are different, sometimes we don't get the same resources, we don't get the same human resources or financial resources, and much of the evidence that could be applied is automatically rejected because there's a persistent concern or fear that that's not going to recognize the fact that children are inherently different. So we always have to grapple with these factors. And I've mentioned that there's significant evidence challenges that come around that and a real need to address this. But we do have this ability to look at evidence differently and to think about research differently when we think about the fact that we aren't just islands, especially in Canada, where we have really great interconnected systems of hospitals and patients. And unlike in the United States, and I do a lot of my work there, we actually have a strong interest and ability to work together, to share patients, to share resources, and to understand patient trajectories and outcomes much better. It gives me a great opportunity to give a huge shout out to the work of Ahmed Nasser, who introduced me today, who I think recognized extremely early the importance of being able to synthesize the evidence that we have at a high level so we have things that we can act on. So there's a number of ways that we've done this in pediatric surgery in Canada. One is very early on, we formed CAPSNet, which is a registry to collect longitudinal national data. So that's information particularly on diaphragmatic hernia and gastroschisis. And that information has been basically collected for more than 15 years now to understand the outcomes and to gather a really great evidence base. And the other thing is to identify this research where it is and bring this all together and synthesize it and create these evidence-based resources. And the next step, which is also being currently led by Ahmed Nasser, and originated by a group of pediatric surgeons, including Sharif Emil, is running these multi-center studies. And this is probably the best that we're going to get at creating good evidence, bringing these teams together to create randomized controlled trials and other trials and produce high quality evidence. But we also have to recognize that there are times when indirect evidence is also appropriate and be open to looking at that. So when we look at this gap in care that we have and the outcomes that we should be improving, there's so many things that we could do to improve and standardize neonatal surgical care. And sometimes it's hard to know exactly where we should begin. What should we look at? How should we think about this? And when we look at complex care, we could go a few different ways. If there is one clear practice in which we are deficient, then it's easy to target that practice and try and turn that over and do better. But most of the time, these things are interrelated. It's usually not just one thing that we need to do, but a collection of things or way that we perform at a team level that we need to target and change. And looking at solutions to complex care often involves us to take a step back and look at sort of broad-reaching practices. And enhanced recovery after surgery is one of these. So for those of you who are surgeons, this is probably something you are very familiar with, enhanced recovery after surgery principles and properties. If you are not a surgeon, you may never have heard of this before. Now, this is something that I was aware of back when I was a medical student and early resident. This was a time when Henrik Kellett, who is a Danish surgeon, started to do things that at the time seemed extremely radical, which is getting his patients walking the day of and the day after his surgery, feeding them right away, getting them out of hospital in 2 days, when typically patients with these type of colonic resections would go home in a week. This sort of thing turned everything around, but the principles were based on diminishing the physiologic stresses associated with surgery. These weren't random things that he was doing. He was really targeting these metabolic, inflammatory, and neuroendocrine injuries that were occurring around the time of an operation and trying to identify interventions that would reduce insulin resistance, preserve muscle and gut integrity, minimize iatrogenic harms, minimize the stress, and bring patients and teams together. And none of these individual elements are enhanced recovery after surgery in themselves. They all work together as a bundle, and that's kind of how enhanced recovery after surgery was started. And this is what a typical enhanced recovery after surgery protocol would look like. They're usually somewhere between 16 and 30 or 40 elements that exist within a preoperative, an intraoperative, and postoperative phase. And I remember the first time I was seeing this feeling like that's a lot of things to try and get one team to do. It must be really hard to make this successful. And it is, but it actually gets down to what's really important, which is the strong team-based implementation. And when this is done in a way where there is focused implementation within teams, structures around enhanced recovery after surgery, the impact of this is dramatic. And so very recently, my colleagues published this study, which is a meta-analysis of 74 randomized controlled trials and over 9,000 patients with implementation of enhanced recovery after surgery. And what they found was across all these specialties, there was a reduction in that pooled risk of complications by 29% and 39% lower overall readmission rates. So pretty dramatic outcome improvements. And the one thing I didn't include here was a very dramatic decrease in length of stay, but I always feel that that's a bit of a distraction when we talk about enhanced recovery after surgery, because I think that was overemphasized at the beginning. And when we think about neonatal populations, obviously length of stay should not be our target. But enhanced recovery after surgery in the adult world has become this paradigm for standard perioperative care. There is virtually not a surgeon in the world who you're going to talk to who isn't familiar with this, and almost everyone you talk to is going to say that they strive for this type of care. It's now ingrained in our surgical guidelines, our position statements, our practice pathways. It's part of common surgical culture in the adult world. And yet in pediatrics, it is very, very, very rarely adopted, and certainly rarely adopted in a way which is standardized and following any kind of recognized pathways. And in part it's because these guidelines just didn't exist for this. We have guidelines across the adult spectrum, and people just weren't certain what to apply and how to apply it in the pediatric population. And that struck me as very strange when you have something which is focused on improving physiologic stresses and not be concentrating on those patients who probably suffer the most significant physiologic stresses associated with surgery. For me, like the neonatal population. But the amount of work in enhanced recovery after surgery that is related to pediatric surgery in specific has skyrocketed in the last few years. Really in the last 5 or so years, we've seen the biggest takeoff. And I think that we're now at the stage of recognizing that the pediatric population could probably benefit from this significantly. So how do we look at using these enhanced recovery after surgery principles and guidelines and use them for our pediatric patients? Now there's a couple of ways of doing this. The standard classic way of looking at enhanced recovery after surgery is that we choose a single condition, a single surgical procedure. For example, IBD colonic resections. And for those patients, we do all of the actions of an enhanced recovery after surgery protocol, from the preoperative through the intraoperative and the postoperative. Now, the other way of managing enhanced recovery after surgery, and we often do this without thinking of it as enhanced recovery after surgery, is something which is a little bit more horizontal. And if we only do one element, it's hard to call it ERS, but it does have those principles. We've done that in pediatric surgery particularly well. What we've done is we've taken something like diminishing the fasting around surgery. Across Canada, we've done an excellent job at not fasting patients for more than 24 hours without giving them fluids and particularly glucose-containing fluids. We have changed that across all the conditions that we're managing, typically in an elective surgery. So it doesn't matter if you're coming in for ear tubes or an orchidopexy or hernia repair, all of those patients are hopefully not going to have prolonged fasting. There's a few different ways of looking at this, and ideally, I think the answer is that you do something between the two of these if you're looking across a pediatric program. Now, some of the areas that have been really successful so far and have, I think, changed practice have been looking at how they can adapt adult enhanced recovery after surgery for pediatric patients. And there's two big trials that are just being published. This one's come out, and I didn't put the other one up, but that one's going to come out in the next month or so. There's the Enrich study and there's the Pursue study. And so the Enrich study, and that's run by Mehul Raval from Northwestern, basically looked at taking an enhanced recovery after surgery protocol and applying it to patients undergoing colorectal surgery for Crohn's disease, for inflammatory bowel disease. And one of the things that I think is worthwhile to look at for this is the kind of work that we need to do as researchers to actually show important findings. It costs like $3.5 million to recruit across 18 sites to get just under 600 patients. And in the adult world, they could spend so much less, so fewer sites, get this number much faster. Like we have like a much, much higher barrier to reach to do studies of this magnitude. And it's a huge hats off to Mehul for getting this done. And his work had a strong focus on implementation. And the findings weren't super dramatic. And I mean, I will say for the adolescent patients, these are probably the patients who are the most kind of buffered against some of these physiologic issues. But they did find their primary outcome was looking at length of stay. And they did find that for those patients where there was strongest adherence to enhanced recovery after surgery, there was a significant decrease in their perioperative length of stay. Now, I think the Pursue study may be even more interesting, and that's looking at complex urologic reconstructions. And for those patients, they have seen across multiple different clinical outcomes an improvement with the implementation of enhanced recovery after surgery. And so keep your eye out on JAMA surgery. That one's coming up soon. So what I have been interested in is looking at enhanced recovery after surgery in the neonatal population. And I immediately recognized that we couldn't just assume that all of the things in the adult enhanced recovery after surgery pathway would work for our neonates. Our neonates are such a unique population. There are things, as I've been mentioning before, that I do think that we should look at and take from the adult world and consider carefully, but we knew we needed to start at the beginning. The neonatal unit also offers some really unique advantages. So most of our patients who are neonates undergoing surgical procedures live within this very well-defined space. And we have neonatologists there. Neonatologists have definitely never heard of enhanced recovery after surgery before. It's not crossed their radar. But they have a very strong interest in robust guidelines, in understanding their data. This has been a really excellent group to work with, and we've worked with them to create these neonatal enhanced recovery after surgery guidelines, and they're so much easier to implement because they're in the same space, all the same people working together every day. It has actually been a real joy working with them to make this happen. But we had to start at the beginning, and this actually, the process that I kind of forced the team into doing for the neonatal guideline has now become the standard for our society and how we create all guidelines, with an assumption that you have to start at the beginning and look across the data and understand what the important interventions would be. And we went through all the steps from creating the guideline group, gathering the evidence, evaluating the evidence using grade methodology, and eventually creating this finalized guideline. But of course, the most important thing is implementing it and testing it, not just publishing it, which we've been doing for the last few years. And so at the end of the day, our guideline has many things about it. This was an intestinal resection guideline for neonates, many things about it that look similar to the adult world, but have a very particular pediatric focus. And we have started implementing it as a pilot in our small site. And what we found is that we were able, first we were just doing a very, very low touch implementation to see how many of these things were easy for people to adopt right away with very little intervention. And many of these did not take a ton of work. That doesn't mean that they didn't have significant changes. Some of them had huge changes from the baseline, but we were able to get many things done and a few things we really struggled with. So we were able to get relatively decent implementation. But one of the first things that we saw was our ability to impact how opioids were being used. And and this is a bit of an aside, I was really surprised by a number of these firm fixed beliefs that my colleagues in anesthesia had and other surgeons had about that neonates are just going to need opioids. Like, that's just a given, that's just accepted. They're all going to need it. They're going to stay intubated forever. There's no point in trying to wean it because they just need it. And what we were able to do is, as soon as we started rolling out our strategy to reduce opioid use, within 2 to 3 patients, we were down to almost no opioids at all. And these patients were extubated sooner, their parents were able to hold them, were able to feed them faster. There were a lot of things that were sort of spin-offs from this, but this was just a pilot study of 10 patients. But there were a few things that happened in the course of this that have changed the way that I thought about neonatal enhanced recovery after surgery. One is we ran into the same sort of issues that I kind of anticipated that we would, and I talked about at the beginning, which is these are rare cases across long periods of time, multiple clinicians. It's kind of hard to get like a huge number of patients at once. But some of the benefits that came from this is that this is this small, isolated unit. Everyone's working together. We had people approaching us like when we were basically just 2 to 3 weeks in and saying, we don't want to just use this for these patients undergoing intestinal resection surgery. Like, why would we not just use this for all of our patients undergoing surgery? Why would we have like a special checklist for these patients? Why would we only think about hypothermia control for these patients? It makes no sense. We want to do it for all the patients. So we're like, this is great, not anticipated. I was expecting a lot more resistance, but the teams really, really liked it. And I think they also found certain things that I hadn't even thought about, like the fact that neonatologists sometimes assume that we wanted kids on antibiotics for a week. We assumed that the neonatologist did. We had neonates on antibiotics like forever, simply because everyone thought someone else wanted this. It really structured our conversation. So my prior fellow, Mercedes, and I undertook to create this ERS guideline for all neonates. And this ended up looking somewhat similar to our prior one, but we took out the things that were intestinal resection specific. Some data had evolved in the meantime. For example, things like the skin preparation that we used, which my colleague Eric Skarsgård had reviewed at the time. At that point, the data wasn't quite strong enough. So a number of different areas that range from communication to fluid use to transfusion guidelines, parental care, all sorts of different things that were all within this neonatal guideline. Now, the one area that we took out, because we developed these separately, were things related to pain management. And we also came up with recommendations for opioid minimizing pharmacologic strategies, as well as non-pharmacologic strategies. And this is one area that seems like magic in the adult world, this idea that many things like glucose and skin-to-skin care actually have a significant impact on pain in neonates. It's a real thing, and we were able to sort of develop guidelines around that. And we're currently at a stage of implementing this at 3 sites, so 2 sites in Canada. ACH is the place where we initially piloted the intestinal resection work, so that's going to be the first place that we roll out this study. The Sick Kids neonatal unit is all in. In fact, they've really pushed us to drop our gestational age and to broaden our criteria. So they've been obviously a huge part of this work. And then the third place is Great Ormond Street in London, which will be the third place where we roll this study out. So we're pretty excited about that. One of the things that I mentioned was that probably the communication tools that we developed in the course of creating these neonatal guidelines were perhaps the most impactful. And this is a very basic, not very exciting huddle checklist that we came up with. And we just mostly made it almost for research purposes, but this is now laminated, and every time a neonate is going to go down for surgery, this gets pulled out, and the entire team reads through it, and it's been incredibly successful. And I think this also points to the importance of bringing together these multidisciplinary teams to have a shared understanding of what the surgical care needs to be in the perioperative space. And that's going to lead a little bit to the second part of my conversation today, which is exploring the role of the surgical safety checklist in the work we do in pediatric surgery. And I'm going to just take a bit of a step back and talk about the history of the surgical safety checklist. Once again, this is something that all surgeons in the room will be super familiar with. We are approaching the 20th anniversary of the surgical safety checklist. It is now a part of hospital accreditation. So if you are doing surgery and you're not using a surgical safety checklist, that is regarded as contributing significantly to patient harm, that's a major issue. But the issue that started the pathway to where we are didn't, of course, begin with a checklist. It began with this unacceptably high rates of surgical complications that were identified by the World Health Alliance, World Health Organization. And at that time, Tolga Wande was tapped with developing a tool that was going to reduce surgical harm worldwide. And a little bit like we were talking about at the beginning, you could choose something like appropriate use of perioperative antibiotics. You could try to address something like surgical training. But the feeling was that trying to find something that addressed all of the different aspects of surgical harm might be the way to go. And the solution for this is what is going to look relatively familiar to those of you who are surgeons on the call, with the WHO Surgical Safety Checklist. Now, every place has adapted this, as it should be, so your checklist almost certainly doesn't look like this, but there are 3 parts to this: before anesthesia, before the skin incision, and before the patient leaves the operating room. There's a number of process checks in this, but even more importantly, there are a series of conversation prompts that are designed to bring the teams together so they have a shared understanding of what that patient's going to go through, what are the things that need to be looked out for, making sure that everyone takes the best care of that patient possible. And this checklist was initially piloted across 8 different sites in 8 different countries, and its impact on a number of different complications was quite dramatic, especially complication rates. But one of the things that really got the WHO's attention is this 47% drop in mortality. And yes, many of these sites were low-income settings, but we saw the same drop in mortality in the high-income settings as well. And so this is really the impetus for rolling this surgical safety checklist out. Now, I will say that when I give a talk like this in Ontario, I am very, very much aware of a couple of the studies that follow this, which has added a bit to the nuance of the discussion. Studies by Urbach and O'Leary that looked at how the surgical safety checklist worked when it was rolled out in Ontario. When it was rolled out in Ontario, there was a checklist mandate. There was not any kind of structured plan for how that checklist should be implemented. And in Ontario, there was very little change in terms of morbidity and mortality and complication rates, what have you. But when you look across the studies that have been done internationally, the impact is undeniable. It's hard to ignore that. We see an overall reduction in pooled mortality of about 20%, and we see also significant reduction in complication rates, even higher, around 30%. But we do see a lot of variability, and this points once again to the importance of implementation and understanding the tool and how it works, rather than feeling that you can give it like a pill and it's going to have an effect. A checklist, any kind of human-based intervention, is never going to work that way. So one of the things that we were interested in, so we're coming up to at this point around 15 years or so after the introduction of the surgical safety checklist, we're interested in how people are thinking about it today, how they're using it today. Has it been abandoned? What kind of state are we in? And so we looked at 5 different sites, English speaking just for ease, and over 2,000 surgical team members and 60 interviews. And what we found is, surprisingly, there is still a very strong belief in the value of the surgical safety checklist from those that we surveyed. A strong belief that it impacts safety, improves communication and teamwork, and people would want the checklist used on themselves and their family members. But we also were noting that the checklist is not used to its full potential. There's a feeling that the checklist may be outdated. There are certain populations that really did not have a focus put on them during the development. The enthusiasm has waned a bit. There's a feeling that it's more of an administrative exercise than a team-based quality improvement intervention. Teamwork is lacking. There's not a lot of leadership investment. Training is minimal. There's real missed opportunities. So sometimes it's tempting to say, well, maybe it's run its course. Maybe it's time for something new. But one of the things I would say is that the surgical safety checklist has probably achieved something, and has definitely achieved something that no other similar tool in quality and safety in general has achieved, and that is this global recognition as a standard of care in safety. And there was a recent global study that looked at quality and safety interventions. Surgical safety checklist by far topped out as the most recognized and the most effective tool that's out there. So if you were to try and find something new, it would be unlikely to be able to achieve this degree of scope and this degree of acceptance, particularly with the decimation of the WHO. So some of the things that we've tried to do is explore what re-implementation of a surgical tool could look like. And this is an area that we've been spending a little bit of time, which is, I actually think, quite exciting. And it is also very appealing to people in leadership levels, because they have seen decades of these cycles of excitement and adoption of new things and rejection of them. And they're very jaded, and they recognize that being able to try and redevelop, re-innovate, and re-implement is probably going to achieve much better and much more sustainable results than continually cycling through new problems and gradually getting your team into a state of innovation fatigue. So we did this at Singapore General Hospital. This is a fascinating hospital. It's huge. They do 92,000 operations every year, which is mind-boggling. It was hard for me to get my head around it, but it is exactly what they do. And they have extraordinarily high efficiency, as you can imagine, but they had, on an ongoing basis, ongoing safety events, wrong-sided surgeries, things like that. They didn't occur at a high level, but they were persistent. And when they did root cause analyses, they found that they were definitely things that could have been preventable with proper use of the surgical safety checklist. And they found that typically what happened in the checklist is that a nurse would read it in the corner, the surgeon would not pay attention to it, and then the surgery would go forward. And so we worked with this team, and we did a complete re-implementation with them and focused on some of the things that they felt were particularly important, and to recreate their checklist. And so some of the things that we found was a significant improvement in no-techs, which is non-technical skills, communication skills, really. They had a relatively poor baseline starting point. One of the key changes that the OR nurses had in this, which also was eye-opening for me, is they said that they wanted people to look them in the eye when they talked to them. And that was something that they actually measure as one of their metrics now, because they felt that there was such a degree of disrespect to the nursing. So that made a big difference in how communication occurred. The other thing that the surgeons really emphasized was the fact that this is a place that is really pushing innovation, bringing in new technology, new devices all the time. And they were finding there were a lot of device-related interruptions. And with this new checklist, that was actually another thing that dropped dramatically, because they had us put in a short pause around device briefing that ended up being very effective. It was something that they felt would be critical to their checklist. Now, the other thing that I think is sort of an important observation is looking at the impact of doing something like this on measures of safety culture. And we often think about culture as like a fixed quality of any kind of surgical team, being that that's your starting point. It's really, really, really difficult to make changes in that. So just to orient you to this slide here, this slide shows a number of the recognized measures of safety culture, of surgical safety culture in particular. And the bars are kind of these benchmarks established by ARC. The orange dots on this represent where Singapore General Hospital was before re-implementation of their surgical safety checklist. The more aqua dots are where they were after re-implementation. And so what we were able to find is that across almost every measure of culture, these teams improved in how they were working together in terms of the psychological safety, in terms of many of these things. And some of this, yes, may be climate rather than culture. It may be all related to this intervention period itself. But I think it also helps remind us that we shouldn't always regard our teams as being static in their behaviors and their attitudes. And the other finding that we had, and I won't spend a lot of time orienting you to this graph, but these run charts of surgical safety events, is that there was overall a drop in terms of the safety events that were identified during this time, which was an exploratory finding, but one that was important to us as well. Now, so we reflected a little bit on this process, and we published some of our reflections in Harvard Business Review. And some of the things that we put into this, and some of the great things about publishing in the non-academic literature, is that yes, we published all of the things that were these hard outcomes, but we also reflected a little bit when talking to our colleagues on some of these kind of softer outcomes, some of the things that really impacted these teams' ability to make a change. And some of these things are matching the care gaps that we see with tools that we already have. And this was something that was really important to this team, and I think is important for us to think about moving forward in our own teams. But when we look at those tools, we should really reimagine what is possible. That approach that we take should have the same kind of momentum and energy and excitement and creativity that it would be if you were starting a new tool from the beginning. And the other thing too is embracing vulnerability. If we don't acknowledge where we're currently failing or where we could be better, it's a lot harder to make positive changes. So those are some of the things that we identified when we were going through our checklist work in Singapore. Now, I want to bring this back to pediatric surgery. I mentioned that some of the issues that we've run into with a surgical safety checklist is a bit of a blind spot in terms of some of the areas that have been looked at. And pediatrics is definitely one of those areas that has been kind of always felt to be like this applies, but never intentional design at a global level in terms of looking at what the surgical safety checklist should do. And so we looked at everything that's been published on the checklist, which is not that much, but what we found is, not surprisingly, if you just took an adult checklist and did as little as possible to it and introduced it and told people they had to use it, it did not work. Poor compliance, negative attitude, it just was not effective. But if you actually went through an intentional process of tailoring it with clinical stakeholders, real patient engagement, and that is in part patient engagement in redeveloping the tool, but even greater part in actually taking part in the checklist itself, particularly in that sign-in phase, and having a strong process of education and feedback. With all of that, we see improved impressions of patient safety, less anxiety, satisfaction, positive team attitude. We don't have a ton of hard outcomes associated with this, but we did see a signal that suggested this was an important thing to do. So we're currently in the middle of a process right now where we're creating a North American pediatric surgical safety checklist. We were fortunate to have last year a shared meeting between CAPS and APSA in Montreal. And prior to this, we'd done a survey of both of our organizations. And then in Montreal, we had a focus group that got together. And what we found is that there are a number of different things that we could look at. And I'm not going to show the too many of the details yet, because we still have to talk with our anesthesiology colleagues. They're preparing to send out a survey, as well as our nursing colleagues. But certainly there's a real difference in how people see the checklist than they had 20 years or so ago when they were first looking at it, and that people recognize that the process component is only a small part of the checklist. Enhancing communication, strengthening safety culture should be an intentional part of our checklist design. We still recognize that preventing wrong-sided surgery is important. There are great opportunities for us to better adapt our checklist for pediatric patients, and now knowing how the checklist works, we can probably be a little bit more creative about looking at, say, focus checklists for neonatal surgery, looking at the role of digitization. These are all things that we're looking at right now. And I think as we move forward, and I'm going to come to a close here to leave hopefully a little time for questions, I really wanted to, if I was going to pull out one thing that I think is really important, is to understand this relationship between QI implementation success and a safety culture. I think of it as a positive surgical culture, in that sometimes it can be very difficult to initiate any kind of QI intervention when you're working in a place where there's resistance. Now, my understanding is that a place like CHEO actually has a really good and positive safety culture environment, which is great. In that situation, your ability to enhance quality improvement is just that much better. But even in places that don't have a really high, really great surgical culture, just finding just a place to start to get in, a little point of leverage to start working in a QI implementation process can end up starting this cycle of improving culture, and it's really a worthwhile process to undertake. So I'll close by saying that I feel like establishing reliability in surgical safety in pediatrics has to be intentional. Specifically for neonates, these are fragile patient population. The surgical systems that we treat them in are very complex. The variation that we see in terms of neonatal care causes harm, and definitely does, and there's plenty of evidence to show that. For us to create this, we have to pursue things like standardization. We have to prioritize communication. Strong implementation, it takes work, it takes time, but establishing a team where that implementation is kind of baked in is one of those areas that is well worth focusing on. And I think through this sort of thing that we can build our stronger teams and eventually create our healthier patients. So thank you all. I really appreciate the opportunity to chat with you today.
Can people hear on screen?
I will repeat your question.
Okay, well, maybe they can hear it. Mary, okay. Thank you so much. This was incredible and really showing great data and great work that you've done. So thanks. Lots to think about. One question I had was, I love the stuff about the surgical safety checklist that you're at the end. And it's something that we've battled a little bit with as well, is that over time the culture around it has loosened. Use that word, and we've had a few serious safety events where I worry that had we had a very robust process, I think that would have caught it, or at least created that culture to speak out. I was curious, when you work with sites re-implementing it, we'll call it, are there things that we should be aware of, or tools, tricks that made it more successful?
Yeah, thank you. I really appreciate that question, and I thought a lot about this at my own site. One of the things I'd start by saying is definitely assume that the data you're gathering on your checklist performance is probably very wrong, is probably completely wrong. Your audit processes are probably terrible. Ours are, in every place that has ever studied it has shown that it's bad. And this is it's another double-edged sword. It's one of the problems of using this as a reporting metric for hospitals, is that there is such a pressure on people to have positive reporting metrics. And there's so many barriers to actually reporting problems that it's not done. And there's another recent study that's just come out that we commented on. We found the same thing. And I actually interviewed, haven't actually put this into a publication yet, but we interviewed all of these OR nurses to talk to them about the performance of the checklist. And what they told us is, if we have someone who's deviating from that, it is a whole lot more work. And we're supposed to talk to people and ask them and stuff like that. They say, we just take them all off at the beginning and say that it was all great. And then you go to these meetings, it's 99% compliance and it looks great. So I guess I'd say, assume that you're probably not doing a great job. And we came up with this measure that we now require people to do. Everything is gameable, so which is checkpoint, and compliance is part of that. But that also includes things like attitude. Do people stop what they're doing when they do the checklist? A number of things on how it's done, rather than is this checklist completed fully. And I'll say and there's I guess I know I'm talking a lot about measurement, but that's where we start. The other problem with measurement is not only can you sort of get a falsely good view of how you're performing, but sometimes if you have an honest team, it may give you a falsely negative view. Certain things, having a good checklist done may not require every element always being discussed. It's way more important that people stop and talk about things. So what I would say is the most important thing is, one, is to try and bring it out of the administrative audit way of thinking to this quality improvement, how do we get better way of thinking. I think that's probably that very first starting point.
Yeah. Thank you, Mary. That's great.
No worries.
I see Erica has a question.
Yeah, Erica, please.
Hi there. Can you hear me okay?
Indeed.
Thank you so much for this wonderful overview on a topic that is near and dear to my heart. I'm a neonatologist here, been practicing for over 20 years, and helped one of my fellows to bring in a perioperative strategy that we adopted from sick kids strategy to try to help our patients do better post-operatively. And this was instigated by our very high rate of wound dehiscence in some of our most fragile patients. And one thing that we did, and we did a lot of the things that you've talked about there, improving nutrition pre and post operatively, fluid restriction, um, opioids, or decreased opioid use. But one thing that we intentionally didn't do was deal with the intra-op management of some of these things. And we did have anesthesia as part of this multidisciplinary team. But I very much respect our anesthesia colleagues, their expertise, and the challenge they have with our fragile patients intraoperatively. But I also recognize there's a huge opportunity for some of these things to happen intraoperatively. And we've noticed that, over the years, the patients are seeming to be more complex going in, but they're also coming out in a shape that we're really behind the 8 ball and really struggling to try to get them back to a steady state and a balanced state with regards to fluids mostly, but also some of the intra-op stability. And so have you seen in the ERAS work, um, an appetite from the intraoperative anesthesia perspective to try to really prevent some of those complications and challenges we're having at the bedside that are happening in intra-op because of massive doses of opioids that are causing hypotension and lots of fluid resuscitation. Your thoughts on that?
Yeah, no, it's a really good point, and it is one of the reasons why I think, in an ideal world, all these people come to the table to create these, because you're right, like, I mean, you do all of this stuff, and then they go into a totally different kind of set of hands and different people, and different priorities, and on both sides, sometimes there is a shared kind of lack of understanding. I mean, for example, the anesthesiologist will sometimes assume, as I was saying, that the neonatologists are going to keep these patients intubated forever, and they're going to give them opioids forever, so there's no point in us doing things differently. Whereas the neonatologists will sometimes say, well, they're going to come to us zonked, and like we'll never be able to, like, so we worked really closely with them and tried to target some of those things that we felt that there was a shared interest in, and perhaps a shared misunderstanding, because I think surfacing those was incredibly beneficial, because everyone's like, oh my gosh, we all want the same thing. How can we do this differently? And so, we are working at, and this is like, is causing a little bit of stress, but like extubating in the OR, for example, which has really pushed a number of these other factors. The fluid thing has been a challenge. And I don't want to go too off script here, but like in the adult world, for example, it's gone too far the other direction. I think PEDS is always a little bit behind. Like, we still over-resuscitate most of our patients. In the adult world, they're now pulling back from this very restrictive fluid management thing, because they found that they were getting high rates of AKI. So now they're like, well, now we're aiming for just a tiny, tiny bit of positive balance. These things shift. So I think that having the anesthesiologist and the neonatologist and everyone there and saying, like, we're all part of this discussion on how we're going to move these patients forward, and have them all at the table is a really great idea. And I'll just add one other thing. The area that we found we're still really struggling with is management of temperature. We cannot keep our patients within a normal range. And one of the things, and this was a learning point for me, is that we were so focused on preventing hypothermia that we'd often have these huge temperature fluctuations, and those are also harmful in themselves, just not on my radar. So I'm saying a lot, but really I think getting them at the table to sit down and talk about it and saying, look, you're part of this team. We want to improve outcomes. There's an opportunity here. We recognize that intraoperative management affects their fluids and thus their wound complications afterwards. Yeah, I'd love to talk more about this though, Eric. You can tell I'm passionate. So.
Yeah.
Yeah.
Yeah, thank you.
It's a great talk.
Thank you.
Thank you so
and
much.
Thank you all for joining online. It's great to sort of virtually meet you. So take care.